My name is Dr. Mark Pearlmutter, and I'm a practicing emergency physician in Boston, Massachusetts. And I'm grateful to be here today to speak about such an important issue. And the fact that all of you are here means that in some ways you're touched by this vulnerable patient population. And I really thank everybody whenever I speak in fora like this, because it really does take a multidisciplinary approach to solving a lot of these challenging problems. I too would like to thank the Congressional members, Napolitano, Ryan, and Sullivan for putting together this staff briefing. And I am here on behalf of the American College of Emergency Physicians. We are a nearly 30,000 members, all emergency physicians throughout this country. And I too oversee a system of emergency departments in Massachusetts, a 10-hospital system called Steward Medical. And I personally oversee 440,000 ED visits a year. And it's no secret that emergency departments have really borne the brunt of the public health ills and served as a safety net throughout this country. The notion of boarding and overcrowding is something that I would imagine most of you have heard of. In a 2008 survey of the American College of Emergency Physicians, 90% of medical directors described boarding and crowding as significant. That is, on a daily, if not multiple days of the week. Boarding, what is it? It's a practice where admitted patients languish in the emergency department waiting for inpatient capacity, waiting for a room upstairs. And it leads to crowding. Crowding is not, like many feel, the result of episodic illness and injuries that present to the emergency department. We welcome those patients because we have the ability to treat those with high quality and fairly efficiently. But it's those patients that sit in languish. Which brings me to the psychiatric or mental health population. Boarding occurs in this population when there's no alternatives available out there. It's a vulnerable population, and a lack of bed creates an environment in which these folks frequently sit and languish, and as I say, slowly deteriorate right in front of us, which only adds to the burden of our healthcare system's boarding and overcrowding. You heard about the deinstitutionalization, the loss of beds, and in the past 2-3 years we've seen further budget cuts that have impacted me locally, but also throughout the country. So as a result of what I call this mismatch, available outpatient and inpatient psychiatric or mental health resources are absent, and it's straining the care that we're trying to provide to this patient population. We have seen a 30% increase in the last 2 years of mental health and substance abuse patients throughout my system. It's not just urban centers, it's throughout. It's rural, it's suburbia, it's teaching, it's non-teaching facilities. This epidemic, as I call it, really knows no bounds. And patients are being transferred once they're admitted hours away from their social networks and any other resources that they've developed over the years. So besides the backdrop of this mismatch, I think the more recent budget cuts have really impacted us. We, as I said, have gone from 8% of our patient population to 12% of our patient population coming in with primary diagnosis of either mental health or substance abuse. But worse yet, it's when you take a snapshot of every hour in time, it's not 8 to 12%. It's actually at about 20%. And that's because these patients are occupying our beds. And so our bed capacity is at 20 and up to, and I'll tell you in a moment, a little survey we've done, up to 52% of all beds in a few hospitals are occupied by this population. So the most vulnerable amongst us does not receive the care that they need, as their illness simply does not go away. And under federal law, once in the emergency department, we have an EMTALA obligation to assure that these patients receive the proper medical screening exam, and if an emergency medical condition is found, to stabilize that condition. That's what we do. I chaired the the co-chair the psychiatric subcommittee of the EMTALA Technical Advisory Group in DC here for over 3 years. And at that time, and that ended in 2009, we found that high utilization in boarding at that time was at epidemic proportions. And again, it's only got worse. We don't have a solution in sight. Let me tell you about a survey that we just did. Massachusetts, we had all the ED directors, 78 hospitals, complete a Monday morning snapshot. We just asked every ED director to say, how many boarders do you have right now that fall under psychiatric diagnosis? How long have they been there? What's the age? And how many beds do you have in your department? And the results of that, and I'm sorry I don't have this posted, but I'll just give you not the granular details, but the larger view, which is we had 80 to 94%. We did it 3 days, by the way, three successive Mondays. And we actually had up to 94% of ED directors responding. Now, surveys are statistically significant if you get 8% back, right? 9, 13, 18. Why is it that 94% responded? Because they care. Because this is a huge crisis to them. And what did we find? So we found that there were 180 patients boarding, on average, 5,335 hours respectively. The total average occupancy was 18%. So almost just under 1 in 5 of the beds available were with a mental health patient or substance abuse patient, and one hospital was 52%. The maximum length of stay was 20 days and 22 hours, and that, by the way, occurred in the same hospital with a 52% occupancy. Overall, 46% of the boarders stayed greater than 24 hours. 15% greater than 3 days, 3% greater than 5 days. And worse, nearly 9% were pediatric. So we also recently, in the state and Department of Public Health, has required all hospitals now to submit data on boarding. And the questions are the following. How many patients do you have per month greater than 12 hours in the emergency department? And of those, what percent are psychiatric or mental health? Any surprise? 83% for the first 2 months that we just started collecting this data for January and February. And surprisingly, just under 2/3 of these are in fact Medicaid or underinsured. 1/3 of them are actually well insured. Something that's a little surprising to many of us. So what about the care that's delivered? So we hear about the proper therapeutic milieu. Has anybody been in an emergency department? Of course you have. It's loud, it's hectic, it's noisy, it's a bit frenetic. It is not what I would call a therapeutic milieu. Most of the time, there is little to no therapy occurring. The patients, as I said, languish for days, and hospitals, emergency departments simply, most of them, just don't have the resource to provide the definitive care during this prolonged boarding, other than the initial determination that that patient requires, alternative inpatient or a stratified level of care that still requires that patient to be accepted somewhere in the community. Think about it. How outraged would you be if your loved one, family, friends sat in an emergency department with pneumonia, heart attack, or stroke with no definitive care? Most of these patients aren't receiving medication. Most are certainly not having any therapy, any psychology therapy. They're not mixing with other folks. They are in a dark, they're in a room without lights many times. There's very little stimuli. It is the worst possible place to put a person in crisis. And what about the staff taking care of them? I can tell you, I've seen this, and I'm a little embarrassed to say this, but a lot of staff feel because for the last 5, 10, 15 years they're not able to do anything about this patient population. There's not a lot of excitement about taking care of them. There's fearful, there's hopelessness, there's helplessness among staff. It decreases ED morale. And what about other patients? So if 52% of your beds are occupied by this patient population, which by the way are fairly resource intense, how can you dedicate resources to those patients with pneumonia, with stroke, with heart attacks? Another sampling of emergency physicians, who will remain nameless, have identified 200 deaths that they have said attributable to prolonged waste boarding, overcrowding in their emergency departments. So this is a real problem. It's not just for the patients that are stuck, but it's also for patients that we'd like to take care of. I won't talk about the financial impact. I think you heard a lot about that. Let me just jumpstart to some potential solutions. In Massachusetts, we've done a lot of different things to help reduce boarding. We put a moratorium on diversion. I'm not sure if you heard it, but there's no diversion. What's diversion? Diversion means that you can tell a hospital or an ambulance not to come to your hospital. And and that's not allowed anymore. So you have to make provisions within your hospital to do so. We have what's called a code help. It's called a code H because when they used to call code help overhead, it bothered a lot of the patients in the hospital. They thought, what's going on? So this code H, disaster activations, and a lot of all hands on board, you know, it helps. But what does it help? It helps those patients who have a destination. It helps the medical, surgical patients. What does it do for the psychiatric substance abuse patient? Nothing, because there's no place for us to put them. So we are trying to embarrass hospitals by publicly reporting. It's the 12-hour data. We'll see where that goes. We've heard from many about some of the contributory factors leading to emergency department boarding. And while I think we all agree that there are fiscal constraints, there's not necessarily agreement as to the root causes of this. And I hope to perhaps share with you very soon the results of a study that I undertook. I received a national grant to look at some of the contemporaneous factors associated with boarding. Age, sex, those are pretty straightforward, but also the ones that are more complicated, which is what component of medical screening resulted in the delay, interestingly, a tiny percent, no surprise. And then what other factors? Well, we hear about them. There's dual diagnosis, which is substance abuse and mental health. There's underlying medical problems, such as pregnancy. There's previous history of violence, previous history of incarceration, sexual predatorship, so on and so forth. But we've heard of those almost anecdotally. We've not seen them. So I'm hopeful with these results that we will have a national model to better understand some of these causes of prolonged boarding, so that we can actually apply some local resources and interventions that could be instituted not just locally, but frankly, can be migrated nationally into real actionable items. I want to also state that, you know, it's easy to talk about stats, but these are real human faces, and I'm just going to tell you about, I worked yesterday, and I was in the emergency department this morning before I flew out, believe it or not, and I'll tell you, there was, I'm going to tell you two patients. One was a college student who found herself with an acute grief reaction due to a 2-year relationship with her boyfriend. She was from out of state. Boston has a lot of out-of-state kids. She was distraught and was contemplating suicide. No previous psychiatric issues. She had insurance, but it was out of state. She presented on a Friday evening. She was fairly distraught. She was not felt to be okay for outpatient. There was no adequate community-based care, both in her college and elsewhere. And she sat in an isolation-type room for 3.5 days. Was just discharged a day and a half ago. During that time, there was no psychiatric intervention or psychological counseling. And she was ultimately transferred 1 hour away. I mean, this is not what we all sit back and desire for care of our patients. And just this morning, I witnessed a 16-year-old boy who we finally asked our psychiatric colleagues to come in, who feel powerless as well to reevaluate. This boy was sent from a local school where he was felt to be troubled, hostility, said some things that made everyone concerned. And there's almost a knee-jerk reaction in many instances to admit these folks to some stratified level of care. He sat in our ED for 3 days and he was finally discharged. During that time, I have to say, nothing was done for him. It was a tincture of time, but 3 days sitting in that environment. I really think we did him a disservice. So I would say in terms of solutions, I would throw out the following. I think without parity, without looking at pneumonia, without looking at stroke, without looking at heart attacks the same way we do with somebody with acute depression, exacerbation of psychosis, new onset psychosis, we're doing a disservice to our fellow countrymen. I think we need to understand the implications of payment for EMTALA, a federal law that requires us to treat everybody so that we can increase the resources available to those emergency department patients who are stuck. I think we need to build selective inpatient capacity building. I think we need to increase community-based resources that are available to prevent the emergency department visits, and we are actually actively working on that in Massachusetts. These things are occurring, but their funding for them is going away. And the worst thing is sort of going along with community-based activation or community-based resource, being 2 or 3 months into it and then having the rug pulled from under you. We need to look at reduction of emergency department recidivism, and we're part of an accountable care organization. We just, part of the Pioneer program, and we just, we need to understand how we can integrate these medical homes that include comprehensive care, including mental health. So clearly we need actionable items. It's a vulnerable population. We all want to treat them with dignity and high quality care and the most appropriate outpatient and inpatient evaluation. And thank you very much for your time.